Hello, and welcome to our very special panel for International NASH Day 2023, the year we've all been waiting for. I am Donna R, the founder and CEO of the Global Liver Institute, which is the world's largest liver patient advocacy organization. Through our partnerships with more than 200 organizations around the world, and particularly on International NASH Day, in our awareness campaigns, councils, and events, we are so excited to represent the interest and move the field forward for all patients with liver disease. But particularly today, we'll be talking about fatty liver disease and NASH with some world-renowned experts who I'm so happy to introduce you to. I have with me today from the UK, Dr. Jude Oben, who is a clinician scientist, consultant, gastroenterologist, hepatologist, and you can see by all the letters, he is very well qualified for any question we may pose to him today. I have also Dr. Mazen Noureddin, who is professor of medicine at the Linda K. and David M. Underwood Center for Digestive Disorders in Department of Medicine. He is in Houston, Texas. And I have the other famous Texan that we know and love and are happy to have on our side in the field of hepatology and in NASH, Dr. Stephen Harrison, who is the entrepreneurial chairman and co-founder of Summit Clinical Research, one of the world's largest, best world-in-class NASH research and liver disease research institutes in the world, often found in San Antonio, Texas, but sometimes also in the UK. Gentlemen, welcome.
Oh, thank you, Donna. It's great to be here today. Great to be talking about all things NASH on International NASH Day.
Fantastic. So our job today is to give people an update about the field of NASH in 2023. It has certainly been a wild ride. And we have made so much progress, though, as I think about this, since we started on the first International NASH Day. And so maybe I'll start with you, Stephen, to what stands out to you in this year in the field of NASH?
Yeah, thanks, Don. I just reflecting back, I mean, we've come a tremendously long way since we had that initial kickoff International NASH Day. Gosh, I can't even remember how many years ago it's been. It's been a while.
Yeah.
6 years. Yeah, I feel like such a young man back then. But what stands out to me this year in particular, I believe, is just the fact that we're so close to having our first approved therapy for NASH. And good news is there's more than one shot on goal. There's a couple drugs that are really kind of at the end that have either filed an NDA or that are in the process of filing a new drug application. But even beyond that, just the amount of data coming in from therapeutic targets that are just below that level are outstanding. We raise the bar every year, it seems, with efficacy, tolerability. We are understanding the pathogenesis of this disease more. And with that understanding comes an opportunity. And that I'm seeing, maybe that's the word for this year, is the opportunity that we see in NASH. Yeah,
I love that. And it's not an easy disease. It's it comes in so many forms. And that's why there are so many medications with so many different mechanisms of action. And so you're doing, the work of several different fields at the same time in research.
You're absolutely right. Let me just say the example I give is it's like you're a bag of Skittles. The bag is NASH, but when you open it up, there's so many different flavors of that, right? And we're trying to tackle that, and we're learning more and more that one size doesn't fit all, but that's okay, because once we know that, we can tackle it. But anyway, my Skittles analogy,
I love it. I can always count on you for a great analogy and metaphor. So thank you. Dr. Oben, in the UK, you have really been at the forefront of making sure that this is a public health issue and tied to initiatives in obesity and diabetes. What does it look like from your perspective?
Yeah, thank you very much, Donna. I think from my perspective, exactly right, that primarily it's a public health issue. And then from the point of view of physicians and patients, we need to be taking more into consideration type 2 diabetes, because that's where most of the patients are. But actually, for those of us who are GI physicians or hepatologists, we don't pay enough attention to those patients. And more importantly still, the diabetologist or the primary care physicians don't pay enough attention to the fact that if your patient has type 2 diabetes, why on earth are you not screening them every so often for NAFLD or NASH? But then, of course, if you say that to them, they will say, oh my goodness, how on earth do I screen them? What do I do with them? Do I do an ultrasound scan every 6 months, every year? What do I do? Do I do a FIT4? Do I do an Oh, are you asking me to do a liver biopsy on my patient every 6 months? Are you insane? But those questions aside, the fact remains, I think type 2 diabetes for me is the one message that I would want to put out there today. Type 2 diabetes, type 2 diabetes, type 2 diabetes. Lean NASH, yes, all right. But most of the patients that are coming through to us with F3, F4, F2 level of fibrosis, they're coming mostly from type 2 diabetes, and we should be doing something about that. And presently, I don't know about you, my colleagues, but here in the UK, we're not screening them. Are you screening them in the US, sir?
I think we're starting to. I love Scott Friedman's story about rolling his FibroScan machine down to the endocrinology suite to just prove to them that their patients with diabetes did in fact have NAFLD. But we shouldn't need such heroic efforts. And maybe Mazen, you answer that question. And look who popped in, patient extraordinaire Karen Hoyt.
Hi.
Lovely Burgundy. We're happy to have you. And we'll get to you in just a second. We were going to ask Dr. Nuruddin a question. How should people be screening? You are the non-invasive testing guru.
Yeah, I mean, I was just going to say it's the confusion is less now, right? Because I think I was presenting somewhere within the last 2 weeks, and I said, we have 1, 2, 3, 4, 5, 6, 7, 8, or 9 guidance that are consistent now. They're telling, actually, that was last week. And I said, we have at least 5 to 6 guidelines now. I think they're up to 9. So ASLD, AGA, ACE, the lean, ALE, and Basel, and they all recommend screening now. So the glass half full, as you guys started in 2021, it started with the AGA clinical pathway, recommending screening, and the story is consistent. So this is the good news. And the story is consistent with starting, as Jude said, type 2 diabetes, type 2 diabetes, type 2 diabetes. I echo that. The additional one to metabolic risk factors, and you start with the FIB4, followed by another test. And now we have options out there, which is ELF and transient elastography. I think the story will evolve over time, and who knows where we're going to end up with machine learning or AI or a robot telling us who is who. But we do have a consistent story as 2021 until now. And you're right, Jude, like people are not picking up that as we like, but it's much better than before that. We can tell them the same story over and over. As Stephen mentioned, there is a drug or more on the horizon because often they ask us, well, what do I do next? Well, they can do a lot, weight loss and exercise, and there are recommendations for weight loss, including using medications and these guidance, but we're going to have drugs in the future, and we can screen them for HCC, and we can make sure they don't get varices and all that. So I think awareness is there, and it's just going to increase with time, and will accelerate with the drug approvals.
That is my hope as well. I've been telling physicians for years, use what you have. Don't worry about, how many, things out there. If you have it in your center to use, please use that, but move forward in screening. So Karen Hoyt, hello, how are you? We're happy to have you. Karen, like me, is a liver transplant recipient. You talk to thousands of patients through your book and your website and all the work that you do on committees now in the US and internationally. So tell us how 2023 finds you and the questions that liver patients pose to you about NASH and understanding their journey.
I have so much to say. I'll try to talk fast. You know me, Donna. I love your work and what you're doing, and I'm very happy to be here with these experienced doctors. And thank you so much for inviting me, Donna, again. First, I just had we just had our FOLD meeting, the fundamentals of liver disease. I'm on that AASLD, and what I love about that is that we're auditing the current curriculum that's on there, and we're looking at what is being put out for the medical community. So I'm going to jump off of that. I'm an educator. So I was out of the classroom for several years. I was on disability. I had hepatocellular carcinoma and ended up with a transplant. And so I understand how education works. But again, I'm an Oklahoman. And so my students, I'm back in the classroom. My students are many indigenous populations and Hispanics, which we know that these people have the type 2 diabetes. So I'm cheering that on. So then I look at, back to my FOLD meeting the other day, how can we crisp up the curriculum? It expires every couple of years. How can we crisp that up for the primary care physicians, for the medical practitioners who are first encountering, maybe in rural America or anywhere in the world? How can we help them with more education? And I'm going to take it a step up because I see these families every day. I see the students in my classroom. And so my big question to government officials and to you, Donna, and to everyone else is, who else besides the doctor can offer this education? Who else do these patients encounter every day? I look into your eyes as doctors and I'm thinking, you're carrying the burden of creating this awareness and of educating people, but they're not coming to you until they're end stage. Like you were saying, the F4. So why can't we spread this burden out? I think social workers, I think there needs to be a program in schools. I think medical health providers, behavioral health providers, everybody that touches a student's life. I see a hand up. I'll take a breath. But you know where I'm going.
I want to ask you a question, actually, just so that I don't forget. Exactly as you're saying, you've mentioned the primary care physicians, right? They are the first doctors to see the patients. And I'm going to ask you as a patient, what should we be telling them to do? Don't wait until they've come to our specialists in the hospitals. What should we be telling them via you as patients to do that they didn't do for you? That's what I wanted to ask you, not to interrupt you. If you don't.
Tip four.
Yeah,
sorry.
I think
Tip four. I didn't hear that.
I'll jump in and then I'll give it back to Karen. What I've heard over and over again as we reached out to general practitioners, primary care, family medicine, and internal medicine is make it simple for us. They already have a long list of things that they have to do. And we're too new to be in a lot of quality measures and incentive programs. And so how can we make it super simple? And so, where the normal lab work that people are already getting can be, automatically calculated into a FIB4 in their electronic health record, an alert coming to the doctor rather than the doctor having to sort of be proactive and do the work, is one of the things that we've heard over and over again is really needed. And so we'll be in conversations with, EHR vendors. That's why it's been so important to get the ICD, 9, 10, 11 coding correctly so that can be automated. But how do we make this as simple as possible? And then Karen, to your point about the other members of the team that need to be involved, I think the nurse practitioners really have a huge role to play in terms of absorbing a lot of this incoming questions that we hopefully are generating, for people. And I'll ask the doctors after Karen, responds about the role of team extenders and, PAs and NPs in your practices and in your research institutes. So Karen, you're thinking on,
Well, specifically, I think primary care physicians, see, my lab work was still good, right? I was riding my bicycle on the Arkansas River in triple digit heat, and I blew up with ascites overnight. So my primary care physician, she grieved with me. She said, wow, when was your last lab? Oh, 9 months ago. And so my ALT didn't go up. I was one that presented well. I had hepatitis C virus. And so I presented well. But I think for the primary care, I think some curriculum. I think we need to have more like looking at diet and nutrition, like you said, helping with that diabetes prevention, and not become complacent and just say, oh, well, you've got high blood pressure. There's a pill for that. Or you've got type 2 diabetes, there's an injection for that. But more like, how can we begin to cook and eat at home? And I know Donna addresses nutrition a lot through her website. How can we begin to bring people back to the home table and help and back to cooking? I think that would lessen the burden on you all. But yes, I agree. But then also, I do think the social workers and the teachers touch the families' lives a lot. They're getting, maybe if they're getting, needy families are getting, then how can we somehow make education available so that we're the whole family? Because what we've got is generational
Right.
pattern habits that's perpetuating liver disease.
Right.
And
Stephen, you have some pithy messages on counseling your patients through with NASH, with nutrition, particularly there in good old San Antonio. Can you share with us some of the advice that you give to your NASH patients? Can I have rice?
Wait, yeah. What kind of rice? No, I mean, no, you're absolutely right. And I mean, this is a hot topic right now. And there's a lot of things to unpack as we begin to drill down on so many of the comments you're making, Karen, that are spot on. Physician extenders are a huge part of what we do now. If we want to deliver that message in a way that conveys with our patients, we need to get down to that level, and we need to have what I call #real talk with them, right? So to speak their language. And in so many places around San Antonio and Houston, I'm sure is the same. There are what I call food deserts, quality food deserts. There are, if you look at where this population of patients exist, as a general rule, it's enriched in Hispanics, enriched in Indigenous Americans, as you noted. And what goes along with that is alcohol often as well. So really teasing apart, there's a lot of things to unpack here. But just speaking about the foodstuffs that our patients eat, they eat what they can afford. And, and if you think about what they can afford, they're not going to go to Whole Foods or to, some of these other high-end places where they have organic fruits and vegetables. They're going to go to, to the pizza place where they can get a large pizza for $5 and feed their whole family, right? And so we have to kind of have that education to say, listen, it's more about the quality of food you're eating. I get that there's a cost component to that as well. So my patients, I tell them, listen, I need you to cut out the bread, rice, pasta, pizza, potatoes, tortillas. And, what's big in Texas is tortilla poisoning, right? I mean, that's what I tell them every day is, the one tortilla, 3 tortillas actually is equivalent in calorie content and carbs to a loaf of white bread. So, I mean, it's pretty dramatic the way you make tortillas, which is just lard, water, and flour, right? And so that's a major foodstuff. The other thing is we talk about the quantity of food that they eat as well, not just the type, but the quantity. And having 2 or 3 tortillas, they have breakfast tacos here. So they eat tortillas for breakfast, for lunch, for dinner. And often my patients will say, well, if I can't have a flour tortilla, how about a corn tortilla? And I said, it still ends in tortilla. Okay? No, not a good idea. And we go through that, with potatoes and rice and chips and all that. But it's a conversation that you have to have, and don't be afraid to have it. The other one is alcohol. And one thing I'll tell you guys that I've made it a point in my practice to do now is when I say, do you drink alcohol? And they say yes, but I only drink socially. I try to dive into how much they're drinking. It's not just the quantity, it's the size. In Texas, everything is bigger. A margarita is not a margarita, right? Oklahoma, right? You're just across the border. You know this, right?
Yes.
So you've got to get at the size they're drinking. And quite frankly, in Texas, beer is not considered alcohol. So you have to have a conversation about beer as well. But I'll stop there. To me, there's a whole conversation we can continue to have around that conversation that's important around nutrition. Exercise is critically important here as well. You're not going to lose weight exercising, but you can sure leave a big fat dent on the planet in the name of metabolic dysregulation by exercising.
I think that's absolutely true. And I am, a big fan of understanding body composition. I'm not a transplant Olympian bicyclist like Karen there is, but I take my little bike to nowhere a lot. But I've been lifting a lot more weights, and my weight hasn't changed, but the body composition has, and I feel that really drives a lot of positive health metrics. And so even for people who were like, I'm not seeing numbers change on the scale, but there are changes going on, with the exercise that is really important. And I think on nutrition, it's a conversation that I know some doctors are afraid of having. And, we work with our friends in the Obesity Society about how to have those conversations in ways that people can, hear and take in and not feel blamed and shamed, but supported. But it is important to have. I wanted to
there are
talk.
ways to make it fun, though. You can make it interactive and fun. Like when I see my overweight patients in clinic, I say, I can't wait to see you again and hope I see a little less of you next time.
There you go.
I mean, you just kind of have these fun conversations. We're laughing about it. But the other point I would need to make that Jude brought up about diabetes is really critical for the primary care doc to understand that NASH is for just being simplistic, is the hepatic manifestation of metabolic syndrome. And if you boil that down to just basic facts, primary care docs know that diabetes is associated with retinopathy, neuropathy, and a couple others, but they don't know about hepatopathy. And so I just add that into the mix. Look, your peripheral nerves, your kidneys, your eyes, and your liver all can be injured by having diabetes. So you can't just talk about retinal screening or peripheral nerve screening or kidney assessment without talking about the liver disease as well. And there's a light bulb that comes on when you say this is the hepatic manifestation of diabetes.
Right. So, Jude, are your nurses carrying the message forward? I'm sure that I know that they're an essential part of the team throughout the NHS, and Louise Campbell would not allow me to say anything differently. But what is the role of nurses and nurse practitioners in taking this message out into the communities and helping patients work through the steps of what it would need to make these changes in their life?
Sure. I think probably, again, as Stephen was saying and Nazim was saying, there are, before answering your question directly, so that it doesn't get lost, right? I think that is so important. But how do we explain it to the primary care physicians, the general practitioners, that look, ladies and gents, there is this really, really simple test that you can do. And at the moment, here in the UK, they get paid X amount if they do all the necessary tests that they're supposed to do for their patients with type 2 diabetes, right? Including hemoglobin A1C, which they have to do every 6 months or every year.
Right.
We're trying to persuade them that when they do the hemoglobin A1C, for crying out loud, just do a FIB4 because the blood's already been done. So just do a FIB4. And we've been telling them recently that an abstract that we've sent in to ASLD, 6% of their patients, of the primary care patients, and non an unlinked anonymous survey, 6% of their patient had cirrhosis without anybody knowing, right?
Wow.
Patients coming in for type 2 diabetes to have their hemoglobin A1C done, unlinked anonymous survey, 6% had cirrhosis. So we're trying to persuade them, for crying out loud, when you do the hemoglobin A1C, do the FIB4 exactly as my other colleague was saying. That I think will be useful. But in terms of the primary care physicians, the persons or the group that we think they should work most closely with are the diabetologists or whoever looks after the patients with the type 2 diabetes. And as for the nutrition, I have to say this, I'm fed up of the number of times that you say to your patients, so what do you eat? And they say to you, but I don't eat anything. Really? You've heard it enough times. I don't eat anything. Do I, darling? No, you don't eat anything. And then you're on to a non-winner, because trying to persuade them that actually we may have ended up where we are because of X number of tortillas overdone is just, it's not going to work. I
just tell people to write it down, write down whatever. I just tell people to write it down, whatever it is they are eating without any changes, just write. You're like, no.
I sent nutritionists, dietitians. I know that that's not my pathway. I will get told off if I went down that line. So please go and see the dietitian. Please go and see the nutritionist, because you clearly need to be educated, as Karen was saying, in terms of the food and the number of tortillas. Please reduce the number of carbohydrates you're eating. And I had somebody recently telling me that grapes were very helpful, very healthy. Yes, but how much of them do you eat? 2 kilos per day. That's like 4 pounds.
Do they have a vineyard? How do they get access to that many grapes a day?
So they had a microbiome that converted the grapes to alcohol.
Exactly.
Wow. 2 kilos per day, yes, is good for you. And I thought, right, okay, you clearly need to go and see a dietitian, nutritionist. So I think the disease here for me at the moment, the type 2 diabetes, we're getting to the point where we're trying to persuade them, the diabetologists at least, that this is important for them to come on board.
Right.
But the one thing that I think is, we're not winning on is the thing that says, why should we bother? Because they all die of cardiovascular disease anyway, right? And the number of times I hear that from other colleagues, I don't know how my colleagues in the US feels, but I'm completely tired of it. It's like, but how can you say that when we're seeing so many patients being transplanted for the disease, and you're still telling me they're all dying from cardiovascular disease? Come on. Are you daft or just stupid? Or what? You understand what I'm saying?
I think they're
like
neither.
you,
And
you're speaking my language. I like it.
This is hashtag real talk.
Yeah.
Sure.
Yeah.
So
Can I go back to
you help a lot of patients work through their nutrition issues and finding an authentic place to rediscover their health. How do you help people?
Well, and I just take it back to shop, cook, and eat. So my little book was like a little pamphlet almost of here's how to shop, here's how to cook, and here's how to eat, because I'm of the generation where that's what we did. And so we're having to teach these newer generations how to shop without busting your budget, and how to
Mhm.
cook and eat at home. But a couple of things were said. One of you said being direct. And so as a patient, I may not speak for everyone, but I can say, I want my hepatologist to be kindly and to say, there you go, honey, you're doing good and you're going to make it. And then walk outside the door and let the nurse practitioner, the dietitian, the whoever else, let them ask those direct questions. My hepatologist that I met first, he was very gentle with me because he knew I was very frightened in his presence. He said, I'm going to hook you up with a hepatologist. And I said, I'm a runner. I'm a cyclist. I said, I know what I'm eating. He said, you're still going to go to the hepatologist visit and I'm going to arrange it and you'll show up on that day. He was so kind to me. And he let the nutritionist have me. And boy, she was like, more of this and less of that. And do you realize how much salt and all of those things? So being direct is easy to say, but that's open for discussion. Do you guys find it harder? Do you find that your patients, we want you to have that sweet bedside manner, and when you're too direct with us, we might leave and cry and get all upset, but is it easy for you to have that person in your office that can say, here's a nutritional pamphlet, and I need some accountability on this?
I think the relationship is important.
Exactly.
I think if
it's
you have that
patient dependent.
relationship, yeah.
You have to speak to patients' love language, right? I mean, the first time you visit, you're just kind of feeling each other out. And for me, it's always just kind of get the facts, ma'am. Let me get the facts. How much are you eating? What are you eating? How much are you exercising? What are your symptoms? How long have you had those symptoms, right? Getting some basic labs, getting some basic imaging. And along the way, you kind of get a feel for, do you want me to let you down slowly? Do you want to just give me the facts right now? How direct do you want me to be? And I think different patients want it different ways. And the good doctors figure that out pretty quickly.
Right. My gastroenterologist would basically give me phrases in Yiddish, which translated in various ways to, you need to slow down. I think some of them translated into, you can't dance at 2 weddings with one behind, and wonderful things like that to get me to sort of pay a little attention to the self-care before I went on my advocacy escapades, but we did work that out about how much. And I've had other gastroenterologists who had to sit with me until the lights were turned off in the clinic, basically slow walking me through the things that I needed to do and sort of finding ways to, work with me in the context of, what I was actually going to do, rather than leave his office and be like, I'm not doing that. And so you have to find that relationship. But I think the peer mentors, people like you and Terry Milton and Betsy Violotti, who help so many patients sort of make this make sense, all the advice that they're getting in the language, that they need, and how to communicate it to their families, are an essential part of this as
right.
well.
And 2 international NASH, so, and like you've pumped that up, you're getting the word out so that people are hearing more, Donna. And I just admire you so much. When Katie Couric's husband died and she got her colonoscopy, everybody knew about it. Breast cancer. We've got 5Ks for breast cancer, and we're beginning to grow in that in liver disease. But we need the liver disease awareness to have less stigma, where everybody can talk about it. And I know there's a lot of talk about changing the nomenclature and saying NAFLD instead of saying fatty liver and NASH. We're working on all of that, where people can say, hey, I can't eat that. Sorry, guys, we're going to have to pick another place to eat because my doctor told me about NASH. And they go, yeah, I've heard about NASH. You've got it. And we can talk about it and reduce stigma.
If these allergies don't take me out, nomenclature may. So we're gonna move right along, Mazen, to you, and talk about the role of research in this. How are patients finding out about clinical trials and clinical research in this area, and what does it mean to participate in a NASH clinical trial?
I will answer that directly. I tell my patients nowadays, I give them the COVID-19 vaccine example, and I tell them the COVID vaccine was not available immediately, and there were thousands of people that had benefited from the vaccine before anyone else, and eventually that they got the benefit without even waiting. And I think the NASH situation is kind of similar. We don't have FDA approved medications yet. We struggle to get expensive weight loss medications, which can help with the NASH patients. We actually have some of these weight loss medications within the clinical trials that they treat the patients holistically and as a whole system, including the weight loss and probably effects on the kidneys, positive effects on the heart, that we know the mechanism, we know the side effects, if any, and they can benefit the patients early. The concept of the guinea pig that a lot of patients unfortunately have, it's still out there. And our job as hepatologists to make sure they understand what they're dealing with, what we're trying to do, and in particular, like when it comes to F3 patients or early cirrhosis patients, I tell them you're really at the edge or cusp of sliding down the hill. So we really have to bring you back, and waiting for drug approved, and especially if I was talking to them last year or the year before or 5 years ago, might not be a good option for now. So it's not just like we participate to help the society, which is important, really important, and it's a task that we should all do. But at the same time, there are obvious medications and obvious mechanisms of actions, and likely it's a matter of time for them to get approved. So why not jump on them now? In addition, just let me tell you what's the last one. A lot of clinical trials now are randomized based on 2-to-1 ratio. And the likelihood and end up on medications is way better than not ending up on anything. And I tell my patients, you should do weight loss and exercise, which is recommended, and we recommend that. But at the same time, hopefully we can add something to you, especially if you're more advanced stage, which most phase 3 trials target.
Yeah, and let me just jump on that. And
Sure.
I think Mazen is exactly right. The issue of placebo does come up. And what I tell people is, look, today, right now, on whatever day that we're talking here, is there is no FDA approved therapy for this. So, by being in a clinical trial, you're getting something better than what standard of care is, potentially better than what is standard of care today, right? Because if I don't put you in a trial, you're on placebo.
Right.
Like
Right.
This is what you're getting. And there's a word in Louisiana we call lagniappe. It means a little something extra. And I tell them, I said, look, you're getting lagniappe. You're getting, in a clinical trial, you're getting access to Dr. Nordine on a monthly basis. You're getting routine follow-up, routine blood work. We're assessing your progress.
Right.
And you have access to a therapy that is potentially the next greatest thing for this disease. Now, will it be? I don't know. Will it work for you? I don't know. But it's better than doing nothing.
Right. I think that, redefining or clarification of what placebo is as like the best standard of care with that attention and frequency of visits. And I remember the first time I was, at a meeting looking at, trial results, and the placebo group, was pretty high to the treatment arm. And I turned to one of our, good friends, Quinton Anstey, and I said, that looks like the effective care, really good care of why that placebo group is having such a great effect, care that they often just weren't getting sort of as free range. But being in the office with, a world-class, hepatologist and trialist, you're really getting, even in the placebo group, you're getting some, really just top-notch, attention to detail, and that can have
That's right. And I don't
great
know,
effect. Yeah.
Mazen can speak to this, maybe Jude as well. How many times have we found extrahepatic malignancy as part of screening in liver disease, where we send patients for an MRI PDFF or a CT1 or an MR elastography, and it comes back with a right renal lesion, turns out to be, renal cell carcinoma. It's caught early. You have a nephrectomy, you're cured. I mean, you see that all the time. I've even diagnosed, literally, no lie, a pulmonary embolism happening at the time the patient was having a scan done. Pancreatic cancer we've picked up, hepatocellular carcinoma we picked up. So there's a lot of reasons to do clinical trials where you're getting access to a level of care that may not even be available in your town, community, or village.
That's
like
right.
And just to jump on that, Stephen, and although here they don't ordinarily pay, but what I also say to them is, by the way, you're going to get exactly as my colleagues are saying, the best standard of care, plus, because you're not ordinarily going to see me every month, every 2 months. You will see me at best every 6 months, every 9 months. You will see me much more frequently than that. We will do more investigations on you. And in fact, we're going to be pampering you, and you won't even have to pay a penny for it. So, and plus the bit about the 2-to-1, there are going to be less placebos than treatment, and the chances are you've got a higher probability of being in the treatment arm than in the placebo arm. So I think it tends to be easier to persuade them to come into the trials. What I have difficulty with is liver biopsies. I've had 4 children, quote, and I've had 2 liver biopsies. Dr. Oben, do not put me through that again. Yes, madam, I won't put you through that again. That, for me, at the moment, is the difficulty, the liver biopsies, trying to persuade any patient to have a repeat liver biopsy as part of a trial. I'm still finding that difficult. I don't know how my colleagues have.
No, I completely agree with you. Let me get back to a comment on lifestyle that Karen mentioned, because it just hit me. It's something that I think is really important. We can tell patients exactly what they need to do, but I tell them behavioral modification doesn't begin until there's heart transformation. Like, the patient has to take that leap, that they have to consciously decide, I'm going to put down the Oreo cookie. I'm going to go exercise. I'm not going to have the chips and salsa. I'm going to have fajitas without the tortilla. I mean, they have to make those decisions. And if their heart isn't right, their behavior is not going to follow. I mean, I've seen that time and time. I'd love to get Karen's take on that.
Well, I think we're very much in the now. I think we're an impulse-driven society right now. And I use technology all the time with my students. It's a great way to teach. I love it. I'm teaching a class on media next week. I think we overuse the media, and we've changed the way our brain chemicals trickle down, and people are given to the impulse. Everybody's heard of the study where the 5 children are given the marshmallows, and if they leave the room, and if you don't eat the marshmallow, you get 2 when I come back. And I
haven't heard that.
Oh, it's a study. It's a great anecdotal story. I know. I think it is a study. It is a study.
Yeah.
But so then they followed these kids over 20 years. The kids who didn't eat the marshmallow went further in life, finished their education. The kids who ate for immediate gratification, they didn't have. So I write a blog every year about to my future self. We've got to begin to think more futuristic. We've got to think about tomorrow. We've got to come into a relationship with our future self. We can't see beyond today. Well, today I'm sick. Today my family doesn't have the money to go buy the groceries. I have a student whose family rides the city bus to the grocery store. They go to the cheapest, the big box, and they use their food stamps, and they're not buying healthy food. They've got to get what they can carry home in their arms. And sadly, you're right about the food deserts, but so at the same time, though, we've got to teach them how to, in motivation, I had a doctor tell me one time, he said, wow, if we could just, if everybody had that same mental state of hardiness, and I don't think we do. I don't think our future generations, but then it's up to us. So now I come back to, who does the patient encounter? You obviously care very deeply. The way you describe your practices, you care very deeply. But who can you align with? Who are these other people that your patients are encountering? And can we educate them, Donna? Can we talk to social workers and people that they meet on a regular basis? I agree. I have people that got the hepatitis C and got on to Dr. Mazan. People who went on the trial because they knew they were going to get the attention they needed. They knew they were sick with Hep C, and they're like, put me on the trial. We begged for it back then. So,
You know, I think that there is a value that, and we can scale this in some of the programs that we're building through the Advanced Advocacy Academy at GLI, and the support, that increasing support we're having for community ambassadors and peer mentors. You know, I know that having a coach, I think everybody needs a coach. You know, my dad was a coach, so I've been coached all my life, and I respond to it. And I have a personal trainer that I report to several times a week. But I've had a virtual coach for several years that would meet, weekly, and just setting up the expectations and working through, okay, you're traveling. How are you going to eat well while you travel? How are you going to not sort of, fall off the rails in these healthy habits that we've built? And maybe just somebody to, hear me complain about what I have to do to, to be healthy, and get that out and then reset. But I think that, the changes that people have to make, particularly to reverse, liver damage if they're already at a fibrosis stage of 3 or 4, even in early stages, to support them through healthy behavioral. It's a lifetime of change that happens incrementally, and you sort of fall off and get back on, and to have a sustained accountability system, whether that's to build that for your entire family. As you mentioned, this is a family, and the Violatis of NASH knowledge are a perfect example of a family that's come together to support the whole family's NASH journey. So I think that consistent support to the messages that the doctors are given is something that we can continue to build infrastructure for. And I think that that's important, including getting people into clinical trials and answering the questions that people might have about, biopsy, what it's like. I've had 6. I don't run to them, but I could have another pretty fast and easy. And those are, the old days. They're just drawing a little X on your side and sort of go in and take a chunk, and lie there on your side for a few hours so you don't, bleed out. So I'm a big fan of non-invasive diagnostics, particularly now that I've had my own fiber scan. But biopsy is not the worst thing in the world. It's certainly not childbirth. So I would definitely have some folks who've had it done a few times to talk her through. So
I'll bring you to
barrier
clinic.
to them getting care.
I'll bring you to clinic and have you talk to my patients about
I'm happy to do that.
Yeah, how easy it is.
I'll wear a crop top. I'll show them just exactly where they, they've taken it. It's so clear. Everybody's like, oh yeah, we see where they've gone before. And thankfully the liver regenerates. And, so I have as much or more as I did before. They decided to take some back piece by piece. But, it is, until we have that replaced. And Mazen, you're in charge of getting that replaced.
Let me comment on this liver biopsy quickly. In the setting of clinical trials, Stephen, I, and others that have been doing clinical trials for many, many years. I think I passed 50. I'm sure Stephen has passed 50 and more. We're really very careful of who we choose to do the biopsy from A to Z, from the place they enter that center, the way it looks, the waiting area, the nurses. So we're very careful about who to choose for biopsy. I moved to Houston, less than a year ago. And I was in LA for 10 years in the medical center, yada, yada. But for the first research biopsy, I went with the patient myself. Because I know this is really important for them. And it takes only one bad biopsy for the patient to hate it for the rest of for their life, and it takes me like a lot of research to find the right place. I went and I had a dinner with the radiologist first, and then I went to his center and I looked at it. And then I went with the patient and I stayed until the end, but she had to wait for 2 hours. And I said, please call me like when you guys after the biopsy. I said, please call me. She's gone, and my team called that night to make sure she's okay. So we're really very careful about these settings and want to make sure, because now it's the requirement by the FDA for the drug to be approved to have a liver biopsy. We still have to do it here and there, but a lot of patients will be like, would you do it again? And this is the answer we want to hear. They will say yes.
I think that's important. What do you think it will take to be able to have clinical trials without liver biopsy required?
Do we have another hour, Donna? We're getting there.
Question we all want to know.
We're getting there. I do think actually there are a lot of open conversations about it. I think we have a new team at the FDA, a new leadership, and I think they are very transparent and open about their feeling about the NITs. I feel like we're making progress. We have a lot of steps, but we're making progress. I think the next steps to clarify which studies are needed to add data to them. But I'm hopeful. I'm optimistic. As you know, and you're part of it, Donna, we are preparing for a prospective study to show how non-invasive testing correlate with outcome, which is something that the FDA asked for. And that effort will be added to the NIMBLE and Litmus and other efforts out there to get the agency what they need and the confidence and meeting the requirements that they have had for other indications.
I think that's such an important message to patients, that there are these consortia, these scientific initiatives and efforts being done around the world to ensure that we, evolve and prove the value and uses for non-invasive testing, whether it's blood-based or imaging-based or AI, assisted. I think that that's important to give people a lot of hope. I remember I was talking earlier today with someone from the early days of companies in the genetic testing arena. And I remember having helped in some of the earliest conversations when there started to be direct to consumer genetic testing and things that we sort of take for granted these days. And I remember just coming to agreements on using the same SNPs, the same genetic samples and indications, so that the different tests could come out with similar results. And so I've seen that move and become accepted and adopted and in well use. And so I know that can happen in this space as well. And so I think that along with the opportunities that you talked about, Stephen, earlier in the drug therapy, the opportunities that we have to make and scale non-invasive testing to assist in screening and treatment response is also an area to be excited about.
Yeah, I think you're absolutely right. And just to add to that, it is an opportunity. And the FDA has made it clear that they're willing to listen to that opportunity. And the other thing to remember, to hope here, the word hope with the FDA, is what they say is they want to have a test that is reasonably likely to predict clinical benefit. They don't say absolutely, definitively, without a shadow of a doubt, has to be linked to clinical benefit. And they remind us of that all the time, reasonably likely to predict clinical benefit. Now, you have to come with the right data. And that's what Mazen he's leading a big effort to try to do that, as well as others around the world are also. But there is hope. There is opportunity, not only in the drug therapy side, but identifying these people through a simple blood test, a simple imaging test, a combination of the two. I think we're really on on the forefront of that. Now, will we get there in 2023? Probably not, but we'll take a huge leap forward in 2023. And I think, first comes the treatment. I think we're going to get a treatment here very, very quickly. And to Jude's point also, once we have a therapy, I don't know how many of my colleagues tell me all the time, when you get a therapy, I'll start to talk to my patients about treatment and about the disease. Well, we're there, guys. So let's begin.
Fantastic. So I'd love to, go around as we bring this to conclusion. There are 80 members now of the GLI NASH Council, from the American Heart Association to the American Council of Sports Medicine, the Obesity Action Coalition, so many academic centers that have been a part of creating this community. If we, really felt the weight of all of those voices, of all of that energy, we'll continue to move this forward. But what is one thing that this we can do collectively, whether it's in the policy arena to support our efforts, or in research, or in putting together clinical care. What message do you want people to take away that they can use to step up for NASH after June 8th? Karen, I'll start with you.
Well, I'm going to go back to my same old thing. The school teacher in me says it starts with education. And so let's do all these. Wow, 81 first, Donna. 81. Oh my gosh. Hats off. Thank you. Thank you for sticking with the message. Education to all of these people in a way that is understood culturally and in the language that people speak. So just a respectful education about NASH.
And I do need to give credit to the team this year for now having our NASH materials in 18 languages. So that is available for free download on our website. And we're doing more each year. So proud of the team. So Mazen, what would you like to tell the assembled partners who are current NASH Council members and future NASH Council members to be able to focus on moving forward?
I will answer that quickly and then go back to it. Awareness, keep working on it. But before I go there, I want to mention something that related to awareness, which is in particular, Donna and Karen. Thank you for what you do. It's not easy to advocate and come out and talk about your disease or what you went through. I know that from myself. I've been a patient. I am a person that I will not talk about my health or share my disease or something like that, except for people I'm close to. So it takes a lot. So thank you for what you do. I have lost patients for NASH cirrhosis. My father lost my grandmother to NASH cirrhosis. I was 2 years old, so I lost her too, but I did not know. So it's this disease that it's silent, quiet, no symptoms. And Stephen and I are sitting here every week, exact same scenario that unfortunately we're used to, breaking the news to the patient that she or he has cirrhosis. And again and again, I don't drink. And again, I have to sit down and explain to them why this happened. And again, they will tell me that they had elevated liver enzymes and they were told that they have fatty liver for many years. This is 2023, for God's sake. We got to stop this. We gonna tell not just the primary care, the endocrinologist, the gastroenterologist, and everyone, you really don't want to be in that seat one day explaining the patient why they had cirrhosis and no one told them that they can get to that. More importantly, they don't want to be in the patient's shoes. So let's get the message out there. There are therapies, there are diet and exercise, there are clinical trials, there are things we can do. Don't ignore that imaging. Don't ignore that ALT and AST. And if you don't have time, send it to the right people. They have time. there are people that dedicated their life to this. Again, thank you for having us, and thanks to you, both of you in particular.
Thank you. Thank you so much for that. Dr. Oben, what message would you like to leave us with?
Yeah, thank you very much. I think the first is just to, how do you say, to respond again to what Mazen has just said, which is to thank both of you again for what you do. I was teasing you earlier that don't forget you're a patient, remember? So, and again, Karen, you and I haven't met before, but thank you very, very much for what you do to bring the disease to the forefront of where it should be. But in 30 seconds, how would I like to end this? I think, again, type 2 diabetes. If you've got type 2 diabetes, if your patient has type 2 diabetes, please, please, please look at their livers. That's it. That's how I would like to end. And again, as Mazen said earlier on, there is that very, very simple test called FIT4, I believe.
Mm-hmm. I think that's an important message, and I know our colleagues in endocrinology are listening to this. Stephen, I'm going to give you the penultimate word.
Yes. Well, thank you. This has been fantastic. It's been great to hear from Karen. Nice to meet you as well. Thank you for all you do. Of course, Donna, as always, leading the charge. I appreciate all that you do as well. Maybe just a word to the 81 members, as well as to our patients. And I think you may have heard me say this before, that I feel like the field, and I feel like for our patients, this is apropos. We're a little bit like an orange construction cone. We're not where we used to be. We're not where we want to be. We're a work in progress. We're under construction. That's to my patients who are making a huge effort to try to change their lifestyle. And it's also to the field. And that's how I'll end.
I love that. We are under construction, and I am so grateful to have you working alongside me, and to all of the partners for International NASH Day and as part of the NASH Council. Thank you.
Thank you.
Thank you.